Assalamu alaikum wa rahmatullahi wa barakatuh. Um, Today, our lecture is about multiple sclerosis, which made by me, Faisal Ghani. Sorry. Uh, anyway, so multiple sclerosis is an immune-mediated inflammatory disease that attacks myelinated axons in the central nervous system. So it destroy the myelin and the axon in variable degrees. In most cases, the disease follows a relapsing remitting pattern. There are there are another patterns, but this is the most common, which is relapsing remitting pattern, which with short-term episodes of neurological deficits that resolves completely or almost completely. We will discuss this in details later. A minority of patients experience steadily progressive neurological deterioration, which is a very bad prognosis or a very bad pattern of multiple sclerosis. So, etiologies. As we know, the cause of multiple sclerosis is unknown, but there is multiple factors that trigger the disease. So we have genetic and molecular factors. For example, it is a disease of young adults, so it affects young adults more than other ages, and it affects female more than male. Also, we have environmental factors, for example, vitamin D deficiency. So, uh, it presents with recurrent attacks at different CNS locations. So, symptomatic episodes are separated in time and space. So, for example, episodes occur months or years apart and affect different anatomic locations. يعني الأحداث أو الليجن اللي تصير في أوقات وأماكن مختلفة، فممكن تصير في شهور متباعدة وفي أماكن في الجسم مختلفة، بس طبعا كلها في السنترال نيرفس سيستم. History. So these are classic multiple sclerosis symptoms. So we have sensory loss, for example, paresthesia, which is usually an early compliant, and we have spinal cord symptoms, the motor type, for example, muscle cramping secondary to spasticity, and the autonomic spinal cord symptoms, for example, bladder, bowel, and sexual dysfunction. We have cerebellar symptoms, and this is a very common triad in multiple sclerosis, which is Charcot triad of dysarthria, nystagmus, and intention tremor. We have also optic neuritis, also very common in among multiple sclerosis, and we have trigeminal neuralgia. So, continuing the history, there are eye symptoms, for example, diplopia, lateral gaze, which occur in 33% of patients. We have also heat intolerance and constitutional symptoms, especially fatigue, which occurs in 70% of cases, and dizziness. Fatigue must be differentiated from depression. However, they can coexist. Also, there are lack of sleep and exertional exhaustion to disability. We have pain. It occurs in up to 50% of patients at some point in their illness, and there are subjective cognitive difficulties with regard to attention span, concentration, memory, and judgment, and depression is a common symptom. So we will talk briefly about optic neuritis because we discussed it before in the cranial neuropathies. So regarding the multiple sclerosis, optic neuritis can be the first demyelinating event in up to 20% of patients. Also, it develops in 40% of multiple sclerosis patients during the course of their disease, and it is characterized by loss of vision or loss of color vision in the affected eye and pain on movement of the eye. Also, we have acute transverse myelitis, but we are talking here about partial acute transverse myelitis, not total transverse myelitis, which is another entity, and it is not manifestation of multiple sclerosis. However, partial acute transverse myelitis is a manifestation of multiple sclerosis. It is characterized by acute partial loss of motor, sensory, autonomic, reflex, and sphincter function below the level of the lesion, and it indicates acute transverse myelitis. But the cardinal feature here is it is partial loss, not complete loss. And also, one should strongly consider mechanical compression of the spinal cord in the differential diagnosis of transverse myelitis. Um, and also, we have fatigue. Fatigue is also one of the common symptoms of multiple sclerosis, and it is described as an overwhelming feeling of lassitude or lack of physical or mental energy that interferes with activities. And also, one should rule out comorbid medical conditions such as infection, anemia, vitamin deficiency like vitamin B12, folic acid, or vitamin D, or thyroid disease before attributing fatigue to multiple sclerosis. Cognitive dysfunction, as we said, uh, it is one of the common symptoms of multiple sclerosis, and it ranges from 40 to 70%. There is no correlation exists with the degree of physical disability, and cognitive dysfunction may occur early in the course of disease. Yeah. So there is no يعني ما في أي علاقة بين مدى درجة الإعاقة الجسدية بالإعاقة الذهنية. والcognitive dysfunction ممكن يجي في بداية المرض قبل ما يصير في إعاقة كبيرة في جسم الإنسان. And these are area على فكرة I'm so sorry for shifting to Arabic and go back to English because sometimes I want to focus on things and I want to clarify it in Arabic. Okay, so there are areas of cognition affected, and it may include any of the following. For example, comprehension and use of speech, attention, memory, visual perception, and planning. And now we'll talk about pain. Pain can be classified as primary or secondary. Primary pain is related to the demyelinating process itself, and is often characterized as having burning, grounding, or shooting quality. This is primary pain. Okay, this is because of the demyelinating process. A secondary pain in multiple sclerosis is primary musculoskeletal in nature and possibly results from poor posture or poor balance as a consequences of the FMS, and there are abnormal use of muscle or joints as a result of spasticity. Heat intolerance is increase in symptoms of fatigue or weakness when exposed to high temperature. There is a sign which is called Othov sign, which is when person exposed to overheating, it may result in blurring of vision. So the Othov sign is blurring of vision resulted from overheating. Okay, and it is usually an eye previously usually in an eye previously affected by optic neuritis, and also the symptoms reversed rapidly when exposed to very low temperature. So when we expose the body to very low temperature, the symptoms are reversed, which is the blurring vision. Physical examination. As you know, because MS can affect any part of the CNS, so all systems must be addressed, including cognition, mood, motor, sensory, and musculoskeletal. So there are common physical findings like localized weakness, focal sensory disturbances, uh, with persistent decrease of perception and vibration, and also hyperreflexia with positive positive Brzezinski sign, and also hypertonia and stiffness in the extremities. So, also we want to talk about ophthalmological examination, specifically about optic neuritis. So, optic neuritis is defined as inflammatory demyelinating condition that can cause usually a unilateral visual loss. Monocular means unilateral, so one eye. Uh, Common findings include disc pallor and relative afferent papillary defect. We discussed this in the previous lecture in the cranial neuropathies, and also altered color vision, visual field defects like central scotoma, where is the central field is blinded, and also retropulpar pain, and it is increased with extraocular movements. Also, there are one of the manifestation is diplopia. One of the manifestations of multiple sclerosis is diplopia. So it is caused either by internuclear ophthalmoplegia, and this is lesion occurs in medial longitudinal fasciculus. Sometimes it's called medial longitudinal fasciculus syndrome. So what is it? It is simply if the patient looks straight, everything is normal, and if the patient looks at the side of the lesion, I mean, the lesion is in the right side. So when he looks right, also everything is normal. But when he looks at the left side, the affected eye cannot adduct, right? So it cannot adduct, and there is positive nystagmus in the left eye. Okay, so the left eye is it has nystagmus. This is characteristic of multiple sclerosis. And diplopia, yeah. So this sign caused diplopia, right? So patient cannot cannot see good. Also, diplopia could caused by ocular, motor, cranial neuropathy, and sixth nerve palsy is the most common manifestation. Third and fourth are not that common in multiple sclerosis. Also, one of the manifestation of multiple sclerosis in in the eyes are nystagmus, and as we discussed before, the Arthov phenomena or Arthov sign. So, multiple sclerosis categories or multiple sclerosis patterns. So we have here, so this is the time, right? So, and this is the disability. So as the line goes right, that's mean longer duration, and as the line goes up, that's mean increasing disability. So first, we want to talk about relapsing remitting, which is the most common pattern of multiple sclerosis. Of course, thankfully, because I mean, it's a good thing, right? So it is characterized by, as you see here, there is no any disability, and then when the first lesion come or when first lesion happen, there is a disability, increasing in disability, but then it improves. So this is a relapse, and this is a remit. So then patient can be symptom free in long time period, and then other attack comes, but then it resolves completely, and then another one, and so forth. Then secondary progressive, which is the same in the beginning, where the first attack and then everything come back to normal, and then another attack, but then suddenly the it 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 turns to progressive, so the disability increasing with time without without remitting. So there is no remitting, progressive relapsing is when um, the course of the disease is uh, relapse and then improve, but with improving there is no symptom free because the disability is increasing with time. So disability is increasing at the same time with attacks relapse and then goes away, but with well, sorry, with the increasing disability. The last one, which is primary progressive, which is uh, uh, primary progressive, where from the start, from the first attack of multiple sclerosis, there is no remit, there is no improving, only steady progressive uh, deterioration of the symptoms or disability. So, what are differential diagnoses? We have spinal cord neoplasm, either primary or metastasis. Presence of cyst and hemorrhage support the diagnosis of neoplasm. So when there is cyst or hemorrhage, we can include the diagnosis of neoplasm. Acute disseminated encephalomyelitis, which is an isolated post-infectious or post-vaccination autoimmune attack on the CNS that leads to diffuse demyelination. Acute onset of motor, sensory, cerebellar, and cranial nerve dysfunction with encephalopathy, progressing to coma and eventual death in 30% of cases. Transverse myelitis. This is what we call the total transverse myelitis, not the partial one, because partial one is one of the manifestation of multiple sclerosis, but this one, which is the total transverse myelitis, it is another entity, another disease. So it is usually called idiopathic inflammatory myelopathy. So this is another name for it. And when we do MRI spine, there is swelling and enhancement in the spinal cord, and it affects longer spinal cord segment than partial myelitis MS. So this is a differentiation between multiple sclerosis and transverse myelitis. In multiple sclerosis, in the partial myelitis in multiple sclerosis, there is a short or separated uh, spinal cord segment lesion, but in the transverse myelitis, the total one, there is long spinal cord segment lesion. Then we will talk about neuromyelitis optica spectrum disorder, and it is previously known as Divik disease or neuromyelitis optica, and it is inflammatory disorder of the central nervous system characterized by severe immune-mediated demyelination and axonal damage predominantly targeting optic nerve and spinal cord. يعني هذا المرض يؤثر فقط على الأوبتيك نيرف والسباينال كورد، ما في مكان ثاني يأثر فيه. One of the cardinal features of NMOSD is the aquaporin 4 immunoglobulin G, which is antibodies that is detected when we do CSF analysis. So it confirms the diagnosis in appropriate clinical setting. This is a table comparing the neuromyelitis optica with the multiple sclerosis. You can read it. I think it's very easy. For example, the distribution of symptoms, as we said, that in Divek's disease, it is the Divek's disease is the other name of NMO, or NMOSD, neuromyelitis optica spectrum disorder. This is the new name. The symptoms are restricted only to the optic nerve and spinal cord, while in the MS it occurs in any white matter tract. Severity and effects is usually severe, and it is mild in MS. So you can read it. If there is any question, we can discuss it later on in the Q&A session. Okay. So investigation. As we know, there is a specific criteria for diagnosing the multiple sclerosis, which is McDonald criteria. It is only for your information. It is not required from you at this level. So and it's not important in the exams or anything else. So but it's just here for your information and for reference. So one of the investigation is MRI, which is the imaging of choice for confirming multiple sclerosis, and this is axial protonal density weighted MRI demonstrate multiple lesions and distribution characteristic of multiple sclerosis. So specifically the periventricular lesion and the more peripheral white matter lesion near the gray matter white matter junction are typical MRI findings in multiple sclerosis. And we have here the MRI of spine, and this is image of spinal cord in a patient with MS. As we see here, this is a zoom of this area. As we see here, there is multiple what we call it plaques or lesion, and it is separated in the spinal cord. This is one, this is one, this is one, this is maybe one. Other investigation is visual evoked potentials, which is performed by having a patient focus on a reversing black and white checkboard pattern, and it delays when there is delays in latency, that indicates the myelination in the anterior visual pathway. Lumbar puncture characterized by presence of oligoclonal bands and intrathecal immunoglobulin G. Management. There are two parts or two pathways of management, either with the disease modifying therapies and either with the treatment of acute relapses. So when patient come with acute relapse, we will treat it with either corticosteroids or plasmapheresis. We'll discuss it in details. And when the patient is in chronic phase or in the remitting phase, so we can give this treatment to reduce the frequency of relapses and slowing progression. Sorry, I know this table is very full with information, but this is it's just all for your information. As what I want you to know is that this medication is called what? It's called disease modifying therapies. Okay, so you cannot say this drug is corticosteroids or acute treatment of relapses, right? So these all are disease modifying therapies, and most of them are indicated for relapsing remitting, as we say here, relapsing remitting, relapsing remitting, relapsing remitting. So most of them are for relapsing remitting. Maybe the last one is for aggressive secondary progressive multiple sclerosis. So this that's all what I want you to know. Some side effects maybe you can know. Specifically, the most important thing is the natalizumab, which increases the risk of progressive. Progressive. Sorry, actually, I forgot its name because progressive multifocal leukoencephalopathy. So this is very important. Maybe an exam could come as a side effect of natalizumab. Okay. This table or this diagram is only for information. It is really good in identifying the agents, the disease modifying agents, and when it discovered through the years until 2018, and also what is the route of administration, and what are the names of the drugs, right? So it's good, but it's not uh, it's not required from you to uh, memorize it or anything else like that. So this is the important thing, right? So treatment of acute relapses, because you could do it even if you didn't, uh, even if you are not in the neurology field. So if a patient with multiple sclerosis came with acute relapse, you want to give corticosteroids, especially IV methylprednisolone, uh, 20, 150 milligram 4 times per day for 3 days, or 500 milligram for 5 days. Then after that, you cannot, as you know, stop the steroids suddenly, so you have to taper on by oral prednisolone, 1 milligram per kg per day for 11 days, as I said, with 4-day taper. So, what is the use of corticosteroids? As we mentioned before, it accelerates the recovery of visual function. So it is good for recovery of visual function, but it doesn't affect visual outcome, and it reduces the risk of conversion to MS within the first 2 years. Right? Plasmapheresis is also important, and it is used for severe attacks uh, if steroids are contraindicated or ineffective. So, thank you very much. I hope this lecture is easy to you. And if you have any question, we can discuss it tomorrow, inshallah, or in the day of Q&A session. مع السلامة.